Kathleen Pike is the Executive Director of the Global Mental Health Program at Columbia University. Dr. Pike has international experience in global mental health discussion and has focused heavily on research into eating disorders. Dr. Pike has published more than 75 articles and book chapters on eating disorders, culture and psychopathology, and global mental health.
Thank you. Thank you. This Global Café, the G20, they're about big ideas. And it's really an honor, it's a thrill that you've decided to join me to imagine with me, what does that mean for mental health? As you entered the auditorium, you received a card, right, or it's on your seat there. I want you to look at the card for a moment. One side is color-coded, the other is an image of a person. This is someone from our global community, a friend, a family member. What you can't see as you look at their faces is that each of these individuals is directly or indirectly impacted in some real way by mental health problems. Let me share with you what I mean. Those of you with the yellow card, raise your hand for a second, right? You're looking at individuals who struggle with depression. What does that mean? It translates into a father who's so impaired he can't make it through his workday. A teenager whose mood is so out of sorts she drops out of school. A mother who numbs her feelings because she can't tolerate the sadness, the depression. A coworker who struggles with mania and finds himself in the police station rather than at work one day. These are individuals with depression, with bipolar disorder, among the most common disorders. Then there are those of you with the orange card, right? Take a look at the faces on the orange card. These are individuals who struggle with anxiety, can come in broad forms, can be very specific, unable to participate in social activities all the way down to not being able to fly in a plane. Obsessive thoughts that wind up leaving someone washing their hands till their skin is raw and bleeding. These disorders are the second most common disorders. They're debilitating, they can be humiliating. And then there are those with the pink cards, right? Those of you who have the pink cards, take a careful look. These are individuals who struggle with one of the most serious disorders, who hear voices, who see things that don't really square with reality, and who can't really tell the difference between the brain disorder of schizophrenia and what the world is all about around them. And then there are those with the green card, right? The light blue card. These are individuals who have eating disorders, who have post-traumatic stress disorder. But the funny thing is you can't really tell the difference as you look at the face. And that's the way it often is with mental illness. The symptoms aren't immediately obvious, and people suffer largely in silence. And when the suffering gets too great, when the loneliness and the stigma become so burdensome, a significant percentage of individuals with mental illness actually can wind up feeling suicidal. So from among those with the light purple card, the desperation can result in people taking their own lives. And we know for a fact from the global data that in these short 15 minutes of my talk, more than 26 people will actually take their own lives by suicide to end their suffering from mental illness. And then there are those of you with the blue or dark purple card. You're the friends, the mothers, the fathers, the brothers and sisters who want to do something but don't really know what to do, don't know where to turn or who to turn to. The truth is that mental health impacts us all in some direct or indirect way, and frequently we don't know where to go or who to turn to. That's the story for all of us around the globe. Mental illness, at this moment in time, hundreds of millions of individuals suffer individually, suffer socially, and we have significant economic loss in productivity. It has a significant impact on the broader G20 goals. What do I mean? 1 in 4 individuals with mental illness at some point in their lifetime will suffer from mental illness. It's true in high-income countries, low-income countries, across ethnic and racial groups, across the regions of the world. And what's most salient about this is that the disability associated with mental illness strikes hardest in that developmental window when we would otherwise expect people to gain in autonomy, to dramatically increase their economic productivity, the years of adolescence and adulthood. So let's go back to the cards that you hold. Each of these individuals suffers in some way from mental health problems, directly or indirectly. And truth be told, we can probably each generate our own individual stories from personal experience. But somehow, for some reasons, we turn away, we look away, we just hope mental health problems will go away. And our individual actions translate into our government policies and our business practices. But you know, it was Einstein who said that the real indication of insanity is doing the same thing over and over again and expecting different results. And we're at that point with mental illness. We're at that point in terms of acknowledging the importance of mental health in the global health agenda. We're at this tipping point. We know that the burden is great, and we have treatments that work. It's time for us to act differently. 3 things that need to happen. We know that we're not investing in getting the treatments to the people who need them. We know that we are not investing in building the workforce of professionals. We don't have enough trained professionals to treat the needs of those with mental health problems. And when governments and businesses fail to recognize that mental health problems impact us all, the impact on productivity means that we are losing significantly in terms of business and government prosperity, economic prosperity across governments, across nations. What does that look like? Mental health budgets are woefully underfunded. I spent more for my coffee this morning than governments have allocated per person for mental health. With the lack of investment in our workforce, we know that 50 to 75% of individuals with real mental health problems never get the treatment they need. The result is that we leave people untreated or mistreated. Take a look at your card again, and now look at the screen. The best that this family can do for their child who suffers with severe mental illness is chain their loved one to a tree. Imagine if that were the best you could do. And lest you think that such deficient care is unique to a rural, remote community, I've got to recognize that in the US, we have more individuals with mental health problems in our prison system than we have in our psychiatric systems. We've got to do better. The cost of mental illness is estimated to be $2.5 trillion this year, with a projection of a climb to $6 trillion by 2030. And let me be clear, this isn't money that's invested in prevention and treatment. In fact, the majority of that projection are costs associated, collateral costs, indirect costs associated with not preventing and not treating mental illness. Additional costs to communities in terms of social services, other healthcare expenditures, housing, and security. And in addition to the trillions of dollars of economic cost, we also, at a business level, are losing hundreds of billions of dollars of earning potential. When individuals with serious mental illness don't have access to treatments they need, they can't possibly perform at their best. And so the reality is that half of all days missed at work, all days absenteeism, is associated with mental health problems. So, we can do better. We might think that this situation is tragic but forgivable, given limited resources. Nobody wants to fight a losing battle. But if there's nothing else that you remember from my talk today, what I want to convey is that focusing on mental health can be a winning battle. We have so much to win here. We know that the burden is great, but we have treatments that work. We need to work differently. We need to think big, we need to think bold, and we need to think globally. I want to highlight 2 initiatives that have tremendous potential in helping us reach this tipping point. First, as I said, we need to invest in solutions that actually close the gap between what we know and what we do. Close the gap between research and treatment, close the gap between the treatment needs and what we can deliver. There are a number of initiatives underway. At Columbia University, our program is working with WHO and a network of institutions to build a community of mental health providers from around the world who are collaborating on building our knowledge base, increasing what we know, and delivering those treatments to those who need them. We now have a community of over 11,500 professionals from from 138 countries. We have the chance to think big, to think boldly, to think globally, to integrate policy, research, and practice. And if we invest in initiatives like this, we really have the opportunity to win big and have a different story when we get to the next G20 Global Café. But to win this battle, we need to put our investments into prevention and treatment. We need to get mental health out of the shadows and acknowledged as a priority around the globe. And in this regard, I want to highlight one other major critical initiative that's underway, an extremely time-sensitive initiative. With 2015 around the corner, work is underway to articulate the priorities that will be specified in the UN Sustainable Development Goals. These priorities will set the roadmap for global health for the next 15 years. Right now, in the draft, there are 17 priorities, and mental health is not among them. It is absent from the UN Sustainable Development Goals. If we perpetuate the insanity of looking away, governments will not have the mandate to focus on mental health. We will not have, which will translate into continuing lack of resources, which will continue to perpetuate the widening gap between the treatments available and the needs of those in the world. But it doesn't need to be this way. If we put mental health in the Sustainable Development Goals, governments will have the priority, the mandate to focus on mental health, which will mean that we have resources for mental health, which will mean that we can begin to close this gap about what we know and what we do, which will mean that we will be able to deliver treatments to those who need them and have a significant positive impact on mental health globally. And that translates, that will have a direct impact on other G20 priorities, increasing population health, improving the vitality of our workforce, expanding economic productivity. We need your help. I invite you, take a look at the back of your card, to visit this website, to join us in the movement to get mental health listed in the Sustainable Development Goals. You have a chance to make an enormous difference in the world. There's a lot of work to do. But the priorities of getting mental health represented in the Sustainable Development Goals will help us win, and win big. There's an ancient saying that if you save one life, you save the world. Take a look at the card you are holding in your hand. Think about an individual who you know personally who suffers with mental health problems, directly or indirectly. You have the potential to transform one life. You have the potential to transform the world. Please join us in making mental health matter. Thank you.
Thank you so much. Now, I'd like to introduce our speakers for this first session. This session is about mental health, and our attention as a community to these issues which affect so many people, which countries suffer more and why. So we'll delve a little bit deeper into this. So I'd now like to introduce our guest speakers. Dr. Kathleen Pike, recognised internationally for her work on eating disorders, their risk factors and evidence-based treatment. She is Executive Director and Scientific Co-Director of the Global Mental Health Program at Columbia University Medical Centre, where she leads the Global Mental Health Program, World Health Organisation collaboration. Dr. Pike has held academic and administrative university appointments in Japan. Please make her welcome. I'll just introduce all of our speakers, and then we can kick off from there. Next is Professor Ralph Martins, who studies genetic risk factors for ageing and Alzheimer's disease. He was instrumental in establishing the McCusker Alzheimer's Research Foundation in Western Australia and is the Director of Research. He was appointed to the inaugural chair in Ageing and Alzheimer's at Edith Cowan University in 2004. Please make him welcome. Next, Professor Michael Breakspear, interested in the basic principles of large-scale brain dynamics, how these arise from and reshape cortical architectures and how they underpin cognitive operations such as perception, inference and motor control. As a psychiatrist with a PhD in computational neuroscience, he also helps to contribute to our understanding of major mental illness such as mood disorders, schizophrenia, autism and dementia. Please make him welcome. A lot of big words for me today, so you might have to just excuse me. And finally, Professor Peter Silburn, a neurologist and Professor of Clinical Neuroscience at the University of Queensland. He's world-renowned expert in the treatment of research of Parkinson's disease-related neurodegenerative disorders in the deep brain stimulation. Thank you. And our moderator, Professor Frank Gannam, Director QIMR Berghofer Institute. Over to you, Frank.
Well, thank you very much. Those of you who are here this morning would have had some warm-up to this session. So what we've asked the speakers to do is to give a short 5-minute max reprise of what they were saying, so we get back into the topics which were raised there. And if I could ask, perhaps starting on the right, ladies first, Kathleen, do you want to present your ideas?
So if you could please play the video. We have a 1-minute video to kick this off.
And it is coming. Somebody's looking at the back. And it is still coming. Yes.
Facing a growing epidemic. Mental illness is the leading cause of disability worldwide. It doesn't discriminate by age, gender, income. But the majority of mental health problems are treatable. When mental health is addressed, the human and economic benefits are huge. In 2015, the UN will decide what its new Sustainable Development Goals will be. Failure to include mental health will cost us countless lives, hurt economic growth and development, and set us back an entire decade. Mental disorders affect 1 in 4 in the world. 85% of people with mental disability live in low and middle income countries, and 75% of them remain untreated. We cannot afford to fail to act. Help us to get mental health on the agenda.
Thanks. So I'd like to just make 3 points as a follow-up to the morning. I have asked the volunteers to pass out the cards. Have you passed those out?
Yep.
Yeah, okay. So I just want to say 3 things. One is we know that mental health problems are significant, pervasive. 1 in 4 individuals around the globe will suffer from a mental illness over the course of a lifetime. The burden is great. Second point is we know that we have treatments that work, and it's time to close this gap. So in that spirit, we have these innovative strategies that bring together policymakers, researchers, clinicians to address mental health needs, to make them a priority, to make it clear that it's not just that mental illness is a burden to society, but in fact that it's not a losing battle, and that we can win, and we have enormous human capital, human potential to recapture if we address mental health.
We need integrated, collaborative, technology-leveraged efforts. I talked this morning about a WHO initiative that has been spearheaded by the Mental Health and Behavioral Disorders Department. We now have almost 12,000 clinicians from 138 countries doing just that, working together to try to close this gap between what we know and what we do. To do this, we need proper funding. We need mental health to be a priority. That's why you've got the card. We need your voice to help us bring mental health to the attention of the UN as they set the Sustainable Development Goals. We need mental health to be a priority, an explicit priority, so that we have the funding, so that we can win this battle. Thank you.
Thank you very much, Kathleen. So we'll hold the questions to the end, and you will have the opportunity to ask questions as well, but Ralph is going to give a thought reminder and provoker now. Yeah, sure. What? Oh, you've come slides. Oh my God, okay, right. Time is going by. Slides, yes. Do you want to come over here, if you wish? Slide 1, please.
Yes. Okay. So can I have the next slide? So I guess the purpose of these slides is just to basically reinforce what Kathy has been talking about, but also to show that there's an overlap between approaches towards treatment for Alzheimer's and some of these mental disorders. Can I have the next slide, please? Okay. So this slide basically shows. Oh, terrific. Okay. So this slide basically shows level of happiness. It was taken from The Economist between different countries, and you can see there's a huge range, and even more so between. This changes between countries over time. So those are the two main take-home messages there. This slide shows you basically the level of burden globally, and of these, the neuropsychiatric disorders is by far the largest level of burden. And over here, if you look at the different psychiatric disorders, depressive disorders are by far the biggest. And if you look at the 15 to 24 age group, this is much more stark, this difference. And if you look at the Australia-Asia level, we see this is fourth highest in Australia and a few of the Western countries. Next. And it begins in adolescence, except for anxiety, which is even in pre-adolescence. I think it just gives you the magnitude of the problem. And this is taken from the US studies. It's increasing with time. As we go up to 2010, it's markedly increasing. And not just in developed countries, this is taken from Taiwan. Drug development approaches, even though there are drugs available, new drug discovery has markedly diminished. But what's turning out to be quite clear is that there are alternate approaches. And this is the work of Professor Michael Burke from the Bowen Institute. And basically, he used N-acetylcysteine. And I'm trying to stress this point is that it's a powerful antioxidant that forms glutathione in the brain. And this is where the similarities come. And he's had some very significant effects on depression, bipolar disorder for a relatively short period of time, up to 6 months, which is rather encouraging. Now, a bit of Alzheimer's. Like I said earlier this morning, when people think about Alzheimer's, they think about memory loss. That's Dr. Alzheimer there, who the disease gets his name. This lady was his first patient. And her first symptoms were not memory loss, it was paranoia. And a lot of the dementias, and particularly even including the Alzheimer's, have a lot of these behavioral issues that are sort of not paid attention to. The hallmarks of the disease are these amyloid deposits in the brain, and up till recently, that was the only way you could definitely diagnose Alzheimer's. Those are the tangles, the amyloid in the blood vessels of the brain, and the plaques. I'm going to stop. But basically, beta amyloid is a central feature of these plaques, isolated in Western Australia. One more minute. And this is just to show you that people from all walks of life can be affected. Genetics does play a role, but there are many other factors. And just to illustrate the importance of the economic cost, this was done by Alzheimer's Disease International, collaboration of 94 countries, and the costs are over 600 billion. So if it was a country, it would have the 18th largest economy. I guess the last slide I want to leave you with, unfortunately it hasn't come out very well, is if you delay the disease by as much as 5 months, this is for Australian figures, you can save $6.6 billion by 2040. And we have that information. I think that's where Kathy and I have something common, is we have information now that we need to implement. Thank you.
Thank you. Obviously, we're trying to get through to discussion. So, are you next, Michael or Peter? Who's volunteering? Come on. Good slides. So,
I could start talking.
just talk. Talk. Go ahead.
Wow, I'm really on the spot here, Frank. So I work at QIMR, as Frank said. I'm a neuroscientist, and my focus is in mental health. And what I thought I'd contribute today, which you won't see, hopefully we'll see in a moment, is the key transitional period of the brain and of us as human beings from childhood through to adulthood. And this has become a key focus of the Department of Treasury in Australia and around the world because we invest a lot of money in ourselves and our children as we're growing up. So from a purely economic perspective, the return on that investment only comes when our adolescents reach adulthood successfully and begin to contribute back to society. Is this going to happen at all? Okay. And the flip side of that is the increase of mental health diseases during that period of time. So why does this occur? We're a fairly unique species on the planet in that our brains take not just months but decades to mature. So most animals do most of their neurodevelopment in utero. Primates spend some months completing their developmental process. High primates maybe a year or two. Part of that involves social and language development. But humans, particularly men, don't receive complete brain maturation until about the age of 24. I'm nearly finished.
Don't go back to the
Okay,
slide.
I won't go back. I'll just show this slide. So here we are, here as a happy youngster, and I do have a pointer here. Point at the machine.
No, ignore him. That's to change the slide.
Yeah, I'm not changing the slides, okay. This is massive technological failure. Okay, and right in the middle, those of you who are from Australia will recognise this infamous young man strutting about in adolescence. So adolescence is a period of profound social and emotional maturation and exploration, and it should be because that's where human civilization comes from. That's where innovation comes from. Language, cultural innovation comes from these delayed decades of neural and social development. But the flip side of that is, well, these are some of the caveats. The flip side, I guess, is this slide, which is similar to what we heard a moment ago, just presented a little bit more graphically. These are the peaks of burden to society of mental illness, cancer and cardiovascular disease. Now, a friend of mine has a cancer and she's only in her late 30s, so I don't want to belittle the middle figure here, but the red circles show you where the peak is, and it's these sorts of figures from Australia that really turned a lot of international thinking around, because the peak here is about the age of 19, and these are disorders like depression and anxiety that persist throughout life, and then they begin to diminish just in time for cardiovascular and dementing illnesses to kick in. Okay, I'll go to the last slide, Frank, and okay, so in summary, here's our strutting adolescent doing all the exploratory stuff that he and his female friends should be doing to bring innovation to society. And here's the timeline of brain maturation, which concludes at about the age of 24. So as a species, we've sort of reached this cost-benefit relationship between delaying maturation and innovating culture, but at the same time, at least this is my opinion, giving ourselves the risk of vulnerability during that period, and that's where most mental illnesses arise from. Thank you.
Thank you, Mark. And we could have the next set of slides, please. So, Peter, we've called them up, and I'm sure they're on their way, the slides, for the next speaker. Peter Silvan.
Look, thank you, ladies and gentlemen, and Frank. We're going to talk about what actually a deep diving into the human future, and I sincerely believe that all the issues that we've heard about the G20 and what we talked here today, the citadel of humanity in the future is here. It's in this brain that we've all got. It's not going to be hearts talking to each other. It's not going to be knees making solutions. It's the brain. And when we get there, we might even see one. But what I'd like to do is kind of talk our way through what can we do in the human brain. We learned a lot from movement issues where we could place electrodes in the middle of the brain and completely relieve things like stiffness, slowness and tremor, like that young gentleman up there. But what we then did was we thought, well, we could learn from that. We're in the human brain. What can we learn? And we started to record from it. So we can now see human brains thinking. And our quest at the moment is to actually look at thought. So while we're doing the surgery, we have an awake person. We've placed an electrode very deep in the brain safely. We've stimulated that part of the brain and improved the function of that circuit. And we've actually looked at the single cells talking to each other. We can look at individual neurons. We can therefore give humans tasks. What stresses you? What do you think of Shakespeare? What do you think of movement? And we can see the neurons working. It's absolutely fantastic to do. Because not only are we helping people, we're learning about the human brain. The devices that we use are now applicable not just to movement problems, forget the slides, not just movement problems, but for neuropsychiatric conditions. We're embarking upon obsessive compulsive disorder, a big trial that we're running here. We're looking at depression, dementia, pain, Tourette's syndrome, even anorexia nervosa. We're looking at these issues in brains that are structurally normal, looking at them but aren't functioning. And the devices that we've got are very important because we can use these in what's called life space that we're working at the APCN. We can monitor people in their own environment, not the falsity of coming in and seeing a doctor in his rooms, but what they're actually like out in the community. And with the Australian CSIRO, we're actually being able to use smartphones to monitor people's activity, not just here, or their mood, but where they are in the community. People with dementia reduce things. People with Parkinson's and other conditions reduce where they go. And we can track this out in the real world. The other thing that we've got, though, and is quite unique to us that we're going to do, is we have a device that's like a cardiac pacemaker that provides the stimulus deep down in the brain. And that device is quite unique because it stimulates the area and helps it work, relieves symptoms. We know that it can work in things like Tourette's and some obsessive compulsive disorder. But we can also take the information out of the brain and put it in a device. So we now have the ability to not just help people, we can see the human brain working. Our quest, I'd like to think, is that we can find abnormal thoughts and sense them and then dampen them down. And that's what we're embarking upon. And it's very exciting. We've been given some devices to do this, and of course it's gone through a whole lot of host of issues. We know, though, that we can help people. We know we can learn about the brain, and we know we can save the community money, and we can then push the resources to where they're needed. We've gone from the single cell to the people out in the community, and that, believe me, is true translational research. It's a nice video. You must watch it sometime.
Very good. Now, we have still 10 minutes. We've captured 10 minutes that didn't exist, and we're going to use those to get some conversations going. I would encourage you to show a hand, but can I just put a question to the panel to get it going? The fact that the United Nations haven't included mental health in as one of the 17 topics, that seems incredible. Why is this? Is it political? Is it just dumbness? What is it? Explain, Kathy. And others may have views as well. Why is it so low on the priority list for the sustainable future?
I don't know. It's really unclear.
You're allowed to have a wild guess.
Yeah, my guess is that I think there are two things. One is that there is reference to health broadly, and so maybe there's the assumption that covers mental health, but we know from a long history that unless mental health is explicitly articulated, it will get buried in the health priority. And the second is that there are a lot of assumptions made about the hierarchy of priorities and our capacity to do something about them. And I think as a field, we need to articulate and we need to stand proud and speak up about treatments that work and about innovations that make a difference and do a better job of talking about what we can do, which will help us do that work even better going forward.
Very good. I'm still looking. There's a hand up. I see one hand up. Well done. 2 hands up. Great. And I'm afraid our 3 hands up, 4 hands up. It's getting busy. Okay. Gone to the man on the left. Yes. Microphone's not coming through. We have some technical issues here, don't we? Yeah. Yes, you're in business.
Okay. You're talking about challenges which I heartily agree with and support. Millennium Development Goals are important. But you're talking about it very much from a so-called developed rich world perspective. The increases in population will be in other countries. They will be in Africa, particularly. There'll be an existing population of poor people in India and China. They will have the same problems they're all living over. How do you translate your findings and ensure that their upbringing and they're taken seriously by the rest of the world? Because you're talking about, I'm not saying a minority, but a relatively small number, and obviously it's important. And it's got to get back on the agenda. How do you translate this?
Could I suggest that some of the others, because I know I want to get the others engaged. So Peter, you've got something really high tech. Michael, you're into the brain imaging. Ralph, you're into the diagnosis. So are you talking for the minority? Peter, Michael, is it? Please answer. Somebody.
We're not talking about the minority. For example, many of the applications that we're doing in Queensland are also directed towards Aboriginal people. Living around the state and Torres Strait Islanders, and this involves rolling out some of the things that we're doing into cheap mobile phone-based platforms. And for example, Peter spoke about those, and the Global Challenge issued one of these, but of course all the winners went to using mobile phones to disseminate information about malaria and other infectious diseases, which are important. But we can also use these cheap and widely available devices for mental health reasons. And there are many other practical lessons that we can learn. You don't need to be in a laboratory to learn the importance of education, equality, opportunity for young people, and these are the things that make a difference. I mean, the burden of mental illness falls outside the developed world just as much as inside it.
Rob? Quick, yes.
Thank you. For the Alzheimer's, we started off with high tech using PET amyloid imaging, as the gold standard, but then we translate that into something that's more easily accessible. We're working on the blood test. There's still a way to go, but the eye imaging, all you need is a little bit of curry powder. Put it in the milk, and you drink it, and you take a picture of the eye.
Okay.
And what we're trying to do now is get a cheaper camera, in the range of $10,000 to $20,000. That's what we're ultimately aiming for. So it's really to get it out there in the wider community.
Kathy, quick word.
I also just want to add, I think that's why these global networks are extremely important. This isn't about making a discovery in Australia or the United States. These networks include low and middle income countries. They're part of building the discovery, part of building the database, and therefore there's not a translation that has to happen later. It's part of the process. It's an integration, and that's what needs to happen.
The floor.
Michael, in one of your graphs showing the mean, just over here, showing the mean age of mean age distribution of mental illness, it was a bimodal distribution, so there seemed to be a peak early on at about 19 or 20, and then a peak later on in life. So does that mean that there are different driving forces between mental illness in younger and older people, and are there different challenges to understanding those driving forces and treating them?
Was there a question?
Simple answer is yes.
Yeah, good man, Michael.
Anxiety, depression, and substance-related issues are onset in late teens, early 20s. Less common but serious disorders like schizophrenia are onset about then. In women, the onset is often a little bit later, particularly schizophrenia. When you move into your 30s and 40s, more inherited disorders like bipolar disorder have their principal peak of onset. As we get into our late 40s, early 50s, the incidence of the many mental illnesses diminishes, but then the brain, cardiovascular and degenerative disorders begins to kick in, frontotemporal dementia, vascular dementia, Alzheimer's disease. So just when we're starting to feel happy, but cardiovascular health underpins good brain health throughout the lifespan.
Good. We move to a different question, if you don't mind. Yes? You ready, Jim?
Yes, I have a question particularly for Kathleen and for Michael. Two things I took from this morning's session were, one, the fact that so many people are blind and all they need is glasses. We're talking about hundreds of millions of people. And secondly, the concept that Egbert referred to, which this concept of the fact that we're handing over really bad habits from the developed world to the developing world. I really want to ask about parenting and the enormous impact that has on this massive increase in depression and associated psychiatric illnesses in the young. It's going up, and I feel that this concept of permissive parenting has profoundly failed in the developed world.
Interesting.
And I'd like to ask both of them.
Good. Responses? I think from all.
I got to go first last time.
Okay.
I think you're absolutely right that there are environmental conditions that we need to consider and issues around family systems that may be part of the context, but I think it's a much more complex story, and therefore we need to be careful about interpretations and the risk of blaming parents. So yes, I think there's a lot that's happening. Rate of development is changing, so we can actually see that certain things are happening earlier across the board in terms of maturation and aging. And there's no question we need to think carefully about ensuring that we don't transfer bad practices.
Peter, good.
Michael?
Yeah.
I'll ask Michael a question. In that, when people talk about those environmental influences, do you see anything in the imaging of the brains of people? What do you see?
Well, obviously, easy things like substance exposure can change things that you can easily measure, like cortical thickness that you can measure in a scanner. Most of the research, I guess, in parenting comes from animal research, where you can have more experimental control over very early life experiences, and so I'm not an expert there, but there's all sorts of experiments showing that rats, for example, reared in the presence of a loving maternal rat have much better basic neuronal, at the cellular level, developmental processes than rats that are deprived of that.
We see in some of our work that it's starting to emerge that when you stimulate the deep brain, you may be actually influencing and reopening up pathways as part of plasticity changes, such that in the very deep brain, if you don't stimulate down there, there's areas that are blocked, and it's the path, it's the tractography that's doing it, and you stimulate it and it opens it up again. And I just wonder whether we're seeing this neuroplasticity, and what a great model to really confirm that if you have that opportunity, particularly in mental health, to follow people through if they peak at that age or whatever.
I think that will develop, yeah.
Well, one of the classic models is, like a key and lock model of mental illness, where something happens in early childhood that creates a vulnerability. And I guess many of that can be mapped into brain networks, and then something happens again later in life, or some other exposure that really then triggers the earlier life vulnerability in those pathways.
At the back, a
One
question.
quick question, yeah.
Last question from the floor.
I just wanted to, it's more of a comment, but perhaps a bit of a question as well. I've taken a lot away from this morning and today, the knowledge, the research, the commitment of the speakers. Just wondering, particularly about health and the inaccessibility and sort of access issues, etc., that we've discussed as well between the developing and developed world. So perhaps, is it a bit of a contradiction that here in these sessions there is this kind of commitment and knowledge, but it is really the G20 countries who are cutting budgets on things like health and education and research and those kind of... So how do you propose to influence the G20 countries in the areas that you spoke about? And what is the track record in the past?
I think that's a great general question on which to end up, and if I can expand on it, this session was about the impact on the economy. Would it be correct to say that you'd probably get more response from the politicians if you stressed the economic burden rather than the individual burden, because they seem to respond to that? Because otherwise it does seem as if a lot of the solutions are there, but the political will is not there. So if you can work your way through that, I'll give you a rest this time, Kathleen. So Peter, you've to see whether, start off, and we're going to work back, bang, dang, dang, last words on this session. Is there a solution which is... And does it only involve the politicians and what we wish them to do? Because otherwise, as the speaker said, there are lots of solutions there, but they're not being applied. And how do you get them applied?
Yeah, I think we should be using forums like this to generate a solid lobby groups, with the basis being the economic dollar. I think that we shift resources when we operate on people. If I keep someone out of intensive care for 6 months or out of a psychiatric institution, then that's a win, and we can take that economic benefit and shift the resource.
Michael, there was a comment this morning just before you start which said there are more mentally unwell people in prisons than in psychiatric wards, and I'm saying that to you because of your daily experience. Not at QI Marburg, I stress, but elsewhere.
Well, I just came from a clinic in the prison, so I can tell you that mental health is both prevalent and it's a core contributor to the reason why many people are in prison, mental health and substance issues, which could be in many cases easily addressed. However, I'll be a bit unconventional and come back to give a bright and positive answer to the question from the floor. In fact, I think the dementia economic burden message in particular is really getting through at the highest levels, and Barack Obama announced his BRAIN initiative, which was $100 million, depending how you look at it. That is a wonderful offer, not yet a huge amount of money though. The EU put $1 billion into the Human Brain Project, and I believe China is also poised with a major announcement. So I think top levels of government are listening to the economic tsunami, particularly from dementia, and we're hoping to capture some of that as well into things that some of us discuss, particularly youth mental health.
Ralph? He still hasn't worked out how to get the microphone.
So I concur with it. I think 15 years ago when we were talking about dementia, no one was interested in terms of the government. And as we're getting closer, that tsunami is getting closer, the figures are getting more severe, we're now seeing big change. I mean, the federal government has put $200 million into dementia research for this year. So that's very significant for what Australia's done in the past. But I think Michael's point that we need to lobby harder, and that's the way we have to do it. And I think public pressure engaging with the community to really push back onto the government is the way to go.
Okay. Kathleen?
I just add that politicians listen to the people. When there's research, the data might be there, but until there's enough pressure on politicians that they would be shamed into not changing, it's just too high a risk to make a major policy shift. So that's why we need each of you to speak up. It can't happen with just data, and it won't happen unless there's a movement that really says, we as the people say this is a priority.
Excellent end point. Thank you very much.